Okay.
Yes.
All right. So we kind of like killed it with regards to the somatosensory pathways and talking about the brainstem and the cerebellum and everything last week. I think we basically beat those structures to death. So we won't be reviewing as much anatomy today. We'll kind of be going more through actual your exam that you're going to start learning about even tomorrow. Your quiz, I told Dr. Patch that I'm probably your best professor ever because she didn't send me the quiz. So God only knows when that's going to happen. But she's going to actually be giving you the neuro exam or the neuro quiz, but I just don't know when. But you have neuro lab tomorrow afternoon from 1 to 5.
She says that she did it in her next PD lecture, which is Monday morning at 8.
Monday morning at 8. I guess everybody should be ready. Happy weekend. Happy Monday. So today we're going to talk about motor function, reflexes, the sensory examination, as well as assessing for cerebellar function. So always when we look at exams, especially any type of exam, but even more so with the neurological exam, you want to look for symmetry, right? So you want to make sure the left side of the body equals the right side of the body. And you're always looking for, if there is something that's asymmetrical or abnormal, where do you think the likely source is? So do you think it's coming from the central nervous system, or do you think this is something more likely coming from the peripheral nervous system? Okay, so remember, central nervous system being our brain and our spinal cord, peripheral nervous system, all of our peripheral nerves, but that also actually includes our cortical bulbar tracts, so it includes our cranial nerves as well. So we want to make sure that we get down very well how to do a normal neurological exam, which I'm hoping that most of us in here are normal, right? Depends on the day. On a Monday, examining me, it's a little shaky. But you hope that you're doing a normal neurological exam on someone, and you want to get proficient at it, because you can get unbelievably detailed on a neurological exam, and you don't have to on every patient. But the main thing with the neuro exam or any clinical exam that you do on a patient is you got to figure out how you do it and do it the same way every time. And that way, when you have developed your routine, it's just like taking a history and physical. You do the same thing every time. It's the repetition. The repetition is what helps you to bring out the abnormalities that might be present. So again, not to kill us, but when we talk about the principal motor pathways, we talk about the corticospinal tracts, so those pyramidal tracts coming down, remembering that about 80-85% of those fibers are going to cross in the medulla, and they're going to head down south toward the lower part of our body. And then we've got the cerebellar system, which accounts for a lot of our balance and our coordination, kind of lets us know where we are in space, so to speak. And then we have the basal ganglia system, okay? Then you also have we'll talk about your sensory pathways, which is mainly the thalamic system. So terms we got to know. Oh, didn't know I did that. All right, paresis, so a state or process of partial paralysis. Then we talk about essentially plegia, so a loss of voluntary movement. When we talk about hemiparesis, we're talking about one limb. Okay, so we're talking about weakness in a leg, weakness in a arm. Okay, and it's typically weakness. It's not typically a flaccid paralysis of that area. We talk about hemiplegia. So we're talking about paralysis of one side of the body. So we're going to include arm and leg on that side of the body. So again, you're then talking typically contralateral aspect of the brain, because the right side of the brain controls the left side of the body. Left side of the brain controls the right side of the body. Talk about paraplegia. We're looking at basically everything with regards to lower extremities. And that can be kind of high, because you can talk paraplegia and you can talk about somebody who is essentially wheelchair bound, and their level of paraplegia might be T4, which is the nipple line. Okay, the AD students should have taught you that by now, because they're fixated on that. Or it could be T10, like T9, T10, which is kind of like umbilicus ballpark. Okay, so it can vary, but it always includes the lower extremities. Versus when we talk about somebody being quadriplegic, or we talk about quadriplegia, we're including both the upper extremities and the lower extremities. And even there, a little bit of gray area, okay? Because you can have somebody who is quadriparetic, and they may have some deltoid sparing muscular strength, okay? They might be able to move their right hand a little bit. So that goes back to where their injury was that they sustained and how much spinal cord function was preserved. All right, big long slide. When we talk about upper and lower motor neuron diseases. So this you'll get more so when we talk in CMS2 in terms of neurology and in terms of the pathophysiology that goes along with it. But if you can think very broadly of upper motor neuron, think primarily brain. So there we're talking stroke. That should be kind of like the one thing you hone in on for upper motor neuron issues. Whereas when you think of lower motor neuron, think more of what affects the nerve at its core, like right at where it innervates the muscle, so to speak. Okay? So there, kind of the number one thing to easily think of is somebody who takes a gunshot wound to the leg and it takes out the nerve. Okay? So yes, they have weakness because they have weakness of the nerve, or they've severed the nerve that innervates the muscle, but they really don't have an issue with the cord itself, nor do they have an issue with the brain. Okay? So they're not a CNS problem. So upper motor neuron, you're primarily talking stroke. Even lower motor neuron, believe it or not, you're talking infections like Guillain-Barré. Even ALS, Lou Gehrig's disease, is considered a lower motor neuron disease. So you have to think of the origin of the issue, and that's how it's going to relate to what you're going to find on clinical exam. So I found a really easy mnemonic, okay, to go by, and it's Storm Baby. So when we talk about strength, both in upper and lower motor neuron conditions, we're going to have less strength. But our tone for the T is going to be increased with an upper motor neuron issue. So again, when you go back and you think about stroke, and you think about those patients and they're rigid in the arm that was weak, they developed that rigidity, okay? Whereas if you had somebody that had a gunshot wound to that arm or to that leg and they severed the nerve, their tone would be gone. They would have flaccid weakness in that arm, okay? We talk about others, so we talk about superficial reflexes, and we'll talk about superficial reflexes today, but those are basically like your abdominal reflexes, your anal reflex, believe it or not, like sphincter tone that we do and we assess for somebody who's had a spinal cord injury, that is considered under the other. So those are absent in an upper motor neuron issue, okay? And those people will develop clonus. We'll talk about clonus today. The people who have a lower motor neuron issue, so again, gunshot wound is kind of the quickest and easiest one, they'll develop fasciculations of those muscles, okay? Fasciculations, you'll basically see quivering that will occur, that won't occur with an upper motor neuron issue. Reflexes are going to be increased in upper motor neuron, decreased in lower. The overall muscle mass, this is where you're going to get severe atrophy. Again, if you sever the nerve, if a bullet was to sever the nerve that innervated the muscle now cannot function, and of course it's going to severely atrophy. Whereas when you talk about maybe a patient with a stroke, they may have some atrophy, but not as severe as somebody who has physically severed that nerve going into that muscle. And then baby is essentially the Babinski sign. So we'll talk about Babinski today, okay? So it's positive and you essentially have upgoing toes in somebody with an upper motor neuron issue, and it's negative or downgoing toes, which is a normal response in somebody with a lower motor neuron. So as you're assessing somebody in terms of reflexes and looking at their strength, if you're wondering, okay, where is the source of the problem? Am I thinking this is peripheral? Is this isolated? Or is this more of a central issue? Should I kind of shotgun it straight to the MRI of the brain? As you're looking at their clinical exam, you can easily start to think, is it more lower motor neuron or is it upper? Okay. So motor function, when we talk about body position, we want to look at how the patient moves, how they walked into the room, how are they walking around the hall. I always have my patients step out of the exam room with me and kind of walk toward a door and turn around and walk back, because you want to see the fluidness of their movement. We want to make sure that we have their involuntary movement is essentially normal. So how's their posture? How's their activity? You're looking everything. You're not just looking at their arms and legs, but you're looking at their face. You want to make sure the movements of their face are symmetrical as well. So you're looking for tone, bulk, and strength. And if you identify anything, again, always going back to, do you think it's more central in terms of spinal cord and brain, or do you think this is more of a peripheral problem? So I don't expect you to know all of these, although you probably learned them in anatomy and phys. But basically, in terms of what is occurring, what muscle is there, what action occurs, the deltoid, we have shoulder. I always say abduction, just so that my pronunciation is not poor. Axillary nerve, and we're assessing C5 and C6. So the problem with kind of the brachial plexus is It likes to kind of have a party, right? So like C5, C6, C7, C8, T1 decide that they all kind of want to party together, and then they don't want to go home with the one that brought them, so to speak, okay? We've been there, right? So we were all in college. So when you talk about, your nerves are all coming, they're all coming from somewhere, but they may not make it back to their same home, okay? So the problem is, as you essentially diverge these nerves, and as they go distally into the arm or distally into the leg, it isn't just solely C5. It's not just solely C7. So as we progress on, we're worried about other nerve intervention and a little bit of cross intervention as we move down the arms and down the legs. So you see that both at the upper extremities, and we see it at the lower extremities. My favorite case that I had many, many moons ago is they had emergently called me to see this woman who had a cervical disc and a lumbar disc. Now, a neurologist consulted us, neurosurgery, cervical disc, lumbar disc, already had the MRIs. And I'm like, okay, so I go in and see this woman, and she wasn't the healthiest protoplasm, which is what you call somebody who kind of hasn't taken very good care of themselves. That's what we used to always call them. So I come in, and basically she's got a foot drop. Her hand hurts. You take 2 seconds to examine her, and you realize she doesn't have a cervical disc. She has carpal tunnel syndrome. Okay, yes, she has a cervical disc on MRI. That's not why she's having hand pain, because it's isolated hand pain that only wakes her up at night, which is carpal tunnel syndrome until proven otherwise. And she's got a foot drop on her leg. But then you start talking to her, and I'm like, when did this happen? Well, my boyfriend was drunk last night, and he fell asleep on me. And he fell asleep across her leg. And I'm like, okay. She had an isolated perineal nerve palsy in her lower extremities. Yes, on MRI, she had a lumbar disc. It was not causing her problem. Her problem was distal into the lower extremities. So for both conditions, I think we did her carpal tunnel surgery. And the other thing, we put a foot brace on her. Basically at first I put a hand brace and I put a foot brace on her. And I'm like, treatment's done, surgical consult's done, okay? So if you know what nerves, as they branch down, innervate certain muscles, it kind of gets you to whether it's being an upper motor neuron versus lower motor neuron, and is this even something that I have to MRI them for? Is this even something that needs a radiographic study, or is this something that we're just seeing and being able to diagnose on clinical exam? But again, the lumbar and the sacral plexus kind of like to have a party as well. So they like to split a lot, I'm sure, as you've learned, and as they progress down the lower extremities. So you have to know essentially what would be the originating nerve, and are we looking then more so at a peripheral issue, okay? So we talk about motor function again. So we look at appearance of the muscles. We want to look at the person overall. Do they look symmetrical? Does the left side equal the right side, even in terms of muscle bulk? Everybody should be pretty symmetrical, right to left side. The size, the contour, you want to look for any atrophy, specifically in muscles that are bigger. And almost in everybody, shoulders are a little bit bigger and bulkier. Hands, you can almost always see issues with hands. Upper part of the thighs and the calves, you can usually easily identify with patients. You want to palpate their muscle for tone. So we'll talk about how to examine someone for tone and resistance today. Look for any type of fasciculations or abnormalities with regards to reflexes. So when we look at muscle bulk, you want to look at the size and contour of the muscles. And kind of the easiest place to go to, honestly, on everybody is their hands. So everybody's going to have a dominance, right? Everybody's either right-handed or left-handed in terms of what you do most of your daily functions with. So if you have somebody who presents, great example, with carpal tunnel syndrome, one of the issues that they develop is thenar atrophy. So you look at the palm of their hand right by their thumb, and it looks thin. It looks wrinkly in comparison to their other hand. Okay? Now granted, that's somebody who not only has carpal tunnel syndrome, but has had it for a while. But if you look at them, their palms should be symmetrical. Most people don't just sit there and squeeze a strength ball with one hand all day, every day, and then do nothing with the other hand. Okay? You should have some type of symmetry. You want to check their shoulders, make sure that they're symmetrical right to left side. Always kind of keeping in line in the back of your mind that muscular skeletal exam. Really, yes, severe curvature of the spine, severe scoliosis can throw somebody off. I mean, if you look at my mother, she looks like this, but shorter. Don't talk, I said that. But but still, if you looked at just her muscle bulk, she's symmetrical side to side. So despite the fact that she has scoliosis, her muscle bulk is symmetrical. For somebody who has asymmetry, is that something that's been there all the time? Essentially, somebody maybe who was born with and early diagnosed with polio and has had that asymmetry for a long time. And do they have then compensatory changes on the other side to account for that deficit? Or is this somebody that you're seeing over and over and over again? You see them every year for their physical exam, and all of a sudden you're starting to notice wasting on one side, okay? Easiest way to check thighs and calves is always load bearing, okay? Almost always, especially calves, almost always if you have someone stand up and you look at them from behind, you can tell if they have asymmetry there, okay? And again, like my friend that I always run with, she basically ruptured her Achilles a couple years ago. So her right calf has always been narrower than her left. And it's a chronic issue. But again, if you look at somebody, you can immediately tell that the bulk is different side to side, okay? You want to look for any type of fasciculations, and really, unless somebody's crazy fatigued by the time they get to your office, and I don't mean just like running 20 minutes late for the appointment, they should not have resting fasciculations of muscles. So there shouldn't look like there's a quivering or like there's ants crawling underneath their skin, essentially, with regards to their muscles. They should be nice and relaxed. If you do see natural fasciculations just in rest, you kind of want to start moving to that reflex exam a little bit quicker. So again, we look for muscle tone. Everybody should kind of have a little bit of tone. Even somebody who hasn't been to the gym, they don't even like drive by the gym, okay? They should still have a little bit of tone to them because you're up and walking and you're moving, and even just that creates a little bit of resistance. But you want to make sure that it's not too much and it's not too little, okay? So when we have increased tone noted, typically you'll see that more so with patients who have had a prior stroke because they have that contracture to the muscle. When we see decreased, you want to make sure that you can hold their forearm and you can shake it. They shouldn't be flaccid in that part of their body, okay? Because then you're starting to worry yourself is this a new issue, or have they had a recent stroke or a recent type of demyelinating process to that nerve root? So again, we talk about strength, so there's a wide variety, okay? Most people have one dominant side versus the other, but again, it shouldn't be asymmetrical that's grossly obvious, okay? Nobody's going to sit there and, well, you guys might pull a squeeze ball on one hand all day long if you're really, really stressed out, but nobody's going to sit there and like lift a 5-pound weight on one arm forever and not do anything with the other arm, okay? So it should not be that asymmetrical. And you want to have the patient actively resist types of movements. So when you're strength testing them, your goal is not to overpower them, but to use a lot of resistance and try to get them to pull against you to see if they are actually equal right to left side. So if the muscles are too weak, you want to test against gravity. Sometimes you even have to eliminate gravity. Basically, you have to kind of elevate the proximal aspect of that extremity so that maybe you can isolate the quadriceps, for example, and kind of just get that muscle movement. That way, maybe they don't have to lift the entire leg. They just have to lift the distal aspect of the leg, okay? So when we talk about movement, who's going to volunteer for me? Somebody's going to volunteer for me. All right, he's going to come volunteer. Yay. This is easier to do rather than just like talking through these pictures, okay? I'm just going to talk about, all right. So if I was to examine Luis, okay, basically I would tell him to make some fists for me. And if I was going to assess biceps, I would basically tell him pull up against me. And I would try to push down, okay? Alright, so basically you pull up, and they should, essentially like how they make a bicep, you should be able to push down, and they should be able to resist that movement. And that would essentially be normal strength, okay? Then I have them hold like candlesticks, okay? Kind of a little bit more so still biceps, getting a little bit of brachioradialis. And then basically right here, still candlesticks, push down, okay? So pushing down, you're going to do triceps. So in the same position, basically just moving your hands twice, you got biceps, a little bit of brachioradialis, and triceps test. Okay? So then if you want to really try to assess pronation and supination, so you're going to basically hold the wrist and you're going to ask them to force to go, try to roll your hand in. Okay? And then try to roll your hand out. Okay, so basically you're assessing supination and pronation. So we're trying to get all the different types of musculoskeletal. Could you guys please? Oh. Hello. So you're just grabbing the wrist and you're asking, rotate in, good, rotate out, good. Now hands are a little bit fun, okay? So you can actually have them just make this, and you can ask them to extend their wrist up, and you try to pull it down, and then flex your wrist down, and I'm going to try to pull you up, and you try to resist me. Okay, so the flexion extension of the wrist. When you do hands, you have them open their fingers nice and wide, and the easiest one to do is you just go cinch digits 2 through 5, and you try to pull them together, and then you can go to the center. And if you want to individually assess all the intrinsics, you basically do this and do that. There we go. So you basically have them pulled apart, okay? And they should be able to resist. The easiest thing, especially when we're talking carpal tunnel, you never knew you were going to like So if you were worried about somebody that had really bad thenar atrophy, so remember your thenar muscle's right here, right? So you basically tell them to pull like this, pull your thumb in, don't let me pull the pencil out. Okay? If they had really weak thenar muscles, I would be able to pull the pencil out. Okay? So again, on your hand, we're primarily assessing ulnar, median, radial nerve, right? We're essentially getting like C6 a little bit, C7, C8, T1, okay, primarily in the hand. So that's what you're trying to get when you're assessing all of your intrinsics. Okay, you're done. And I'll get another volunteer for the lowers. I need a girl. Okay. And I need a she. All right. So, if you need to stand in the back, you can stand in the back. That's fine. Okay. So when you're assessing strength for the lower extremities, it's very easy. Always got to think about what joint you're assessing. Okay. So remember that when we're talking hips, forward flexion is straight up. Okay. When we're talking knee, flexion is back. Right. Extension is out. Whereas hip, I feel like I'm going to do a cheerleader move here. If you're doing hips and you're going back, you're kicking back. That's extension. So you have to look at the joint you're trying to assess and the muscles that are going with it in terms of what you're looking for in terms of strength, okay? So what I would always do is I would have her. All right, so I would have her just pull your knee up, don't let me push it down, okay? So she would just lift her knee up and she wouldn't let me push it down. Do the other side. And then you always have to be careful with this one because I had a lady kick me one time. So I hold at the base of the ankle, and I just say kick out against me, okay? So that's primarily getting quads. Again, a little bit of anterior tibialis, but primarily quads. And kick out against me. Good. Pull your toes up, still then push them down, okay? So again, anterior tibialis, and even getting extensor hallucis longus there, okay? And then pull your toes up. Good. Push down against my hand. Push like you're pushing on a gas pedal to the car. That's what everybody always says. Gas pedal to the car. Everybody knows. Everybody's got a lead foot. Okay. Hips out, so we're going to do hip adduction, okay? So I go out, push out, okay. And then, sorry, should have picked somebody's hands. If we're going in the center, you just put your knees, you put your hands on the center, pull against my hands, and you just pull your legs apart. Okay? Whatever. All right. Kind of thoroughly, But that's basically how you can do a very quick musculoskeletal exam on somebody, okay? Upper extremities are very easy. Basically, everybody knows what you're talking about. Pull up here, push down against me. Other things that you can do if you really want to assess deltoid and you truly are worried, let's say you've got a patient who might have some shoulder issues, so you had them essentially push out against you because you're isolating just the deltoid muscle. There are films in here or pictures in here. So this is essentially all upper extremity. Okay, getting hands. I don't really like them to squeeze necessarily. I think the easier one is to put the pencil between the thumb because really then you're starting to isolate a little bit more of the thenar muscle there. But again, here, if we're talking lower extremity, remember what joint you're assessing when we talk about flexion and extension. okay? Because flexion and extension at the knee is different than flexion and extension at the hip in terms of how you're moving. So again, lifting up, pulling in, pulling out. If you really wanted to isolate essentially the gluteus muscle, you would essentially lay the patient down and you would put tension behind them on their hamstring and they would lift up against you, okay? Versus if you wanted to isolate the hamstring, you could basically have them pull up on the gastrocnemius, okay? You could assess the calves a little bit more. I tend to assess the calves when people are standing. It's one of the things that I have them do when they're walking in terms of gait, because I just have them walk up on your tiptoes and walk back on your heels. And then you can pretty much assess strength of the gastrocnemius, because I was watching a guy yesterday at Publix, and he was doing this. You know, basically at a foot drop. And you can hear them slap the floor differently when they have weakness of the gastrocnemius and weakness of the anterior tibialis than somebody who doesn't, okay? Yes, on that patient, you also get the atrophy that you're obviously going to notice on clinical exam, as long as they have a skirt on and they don't have pants on. But, you know, if you have them in a gown, you would be able to see, oh, they're weak on that side. Let me see if they actually, when they walk, they slap the floor a little bit louder. So you get all the way down to the foot. But basically what we're doing is we're grading the patient, essentially grade 0 over 5. Everything is over 5. So 0 over 5 is no contraction whatsoever. So a patient who has flaccid weakness, complete weakness, think of a stroke. That would be somebody with a 0 over 5, okay? Versus somebody who has normal strength, who's a 5 over 5. And then you can even get to the actual neurologist who will come in and say, well, they're 4 plus over 5. So it's like, they're a little bit better than a 4, but they're not quite a 5. You know, so they'll do the 4 plus, the 4 minus. It's kind of a gray area. You know, everybody's definition of plus and minus kind of gets very, very fine-tuned. But basically, a regular 4, they should have some resistance. They can resist against gravity, but they're going to have a little bit of weakness there. Versus somebody who's a grade 2 or 3, again, a little bit of a gray area there because you have to eliminate gravity. And was it Newton? Einstein? Who was it?
Newton.
Newton, right? Eliminating gravity is a little bit challenging, okay? But again, if you wanted to isolate one motor group, you basically have to help them lift the proximal aspect. So you maybe lift the proximal aspect of the leg and say, hey, can you extend your knee? Okay? Then you might be able to assess a little bit more just isolating the quadriceps without having to really use hip flexors and without having the extra weight of the proximal aspect of that extremity. Does that make sense? Okay. So we talk about a sensory exam. Again, we're evaluating pain, we're evaluating temperature. Typically, we don't have to evaluate temperature, which is nice. Proprioception, vibration, light touch, tactile localization, discriminatory sensations. And again, we're always looking for, does it make sense with what we found on their motor exam? Does it make sense with the things that we listened to the patient say during their history in terms of what their complaints are? And again, do we think it's central or do we think it's, somebody should assess my motor function. Do we think it's central or do we think it's peripheral based on what we saw on their motor exam? So again, we have analgesia, so basically an absence of pain sensation. Most people don't have that. Hypoalgesia, so it's a decreased sensation. Hyper is more common. Anesthesia is an absence of touch, so you'll get that in some patients who have had a stroke in the thalamus, that they basically will not pull their hand away from a hot plate, for example, and they'll end up with very bad burns. Hypoesthesia is a decreased sensation, and hyperesthesia, so typically you would deal with more so in like your patients who've had nerve root damage in the lower extremities or in the upper extremities. They may have a hyperesthesia. They may have an increased sensation. I feel like ants are crawling, something's running down my leg. Half the time you'll have patients who say they thought they literally urinated on themselves because what they felt was something running down their leg because of that increase in sensation, and that's truly related to the nerve. They obviously did not urinate on themselves, but that's a very common complaint that you'll hear with patients, especially with lumbar disc disease. So we talk about sensory exam, and the best way to think about sensory exam is, you know, your olfactory nerve is a sensory input, right? Sense of smell. So you can walk in to the place with the best smells and you can walk into the place with the worst smells. And eventually, you kind of don't smell it anymore, right? We've all walked into a place and we're all like, ooh, what's that? And then about 5 minutes in here, it doesn't bother you anymore, right? We become desensitized to it. Same type of thing happens if I were to sit here. What's your first name? I knew your last name. Crystal. If I was to sit here to Crystal and do this, she might want to hit me, but it probably wouldn't be as sensitive in 10 minutes. It'd be annoying, but not as sensitive in 10 minutes as it is right now, okay? So you have that desensitization that occurs. So you don't want to sit there and stretch out your sensory exam, or you're not going to get an accurate sensory exam. So you want to make sure that you're paying special attention to where you think your symptomatology is and focus your sensory exam to that area. And then you want to make sure that you have symmetry, and if you have a varying pace. So again, if you sit there and tap somebody on the forehead, if I did that to Floyd for 5 minutes, he might hit me. Yeah, probably, right? That'd be okay. But if I was to vary my pace, I'd throw him off his I'd throw him off his groove a little bit. He wouldn't know when to hit me. Okay. So when we talk about, we want to make sure we map out boundaries. Always, you want to make sure that you test this on yourself, especially if you're going to hit somebody with a sharp object, like a little pin. You want to tap it yourself with it, and before you're going to tap your patient. So you say, I'm just going to tap you like this, okay? Or tap them on an area that you know is not an area of concern. So if you're worried about a lower extremity issue, take their forearm and tap their forearm and say, I'm just going to hit you like this. I'm not going to hit you any harder. I want to see how the sensation is. Because you're wanting to see what is normal and where does it change to abnormal. So you want to delineate out that area. Again, we'll talk about dermatomes, but really looking for the dermatome in the body that might be abnormal. And are we crossing dermatomes? Do we have a couple different nerve dermatomes that we're worried about? Or are we really just worried about one area? Or are we worried about that area and everything distal to it is gone? Okay? So you're think about this in terms of a trauma patient. Okay? And they come in and you're worried about a spinal cord injury and you're worried at what level have I lost sensory function? Because maybe they're not moving their legs, kind of moving their arms. But what's our sensory level? Our sensory level might not equal your motor level. Okay? So you want to make sure that you're going to the affected area and making sure that it matches what you're finding on motor exam and on reflex exam. So we talk about dermatomes, right? So T4 is essentially your nipple line. Some of these kind of cross over. Again, got to remember your brachial plexus, got to remember your lumbar and sacral plexus. All those nerves kind of come to the party, but they don't go home with the same person, right? So the patterns and the dermatomes can overlap a little bit. So it's very important that you delineate which one you're looking for. But typically when we talk about the thorax, when we talk about the thorax and the abdomen, we're looking at T4, essentially nipple line, umbilicus is about T10. So it kind of gives you a good idea that if your sensory level is somewhere between your nipple line and above your umbilicus, probably about T6, okay? And then you can go back and you can look at the radiographic imaging and look at their motor exam and make sure everything matches. Then it makes sense the fact that they don't have an anal reflex, right? That they don't have anal tone because those nerves have already been taken out by their injury. Everything starts to kind of come together and fits. We talk about spinothalamic tract, so again, pain and temperature, crude touch, so kind of very, very, can you tell if it's very, very sharp or very, very dull type of thing. And remember the fibers that are going to cross and go up, and they're going to essentially go through the thalamus, and they're going to end on that sensory cortex in the brain, okay? So easiest way is to use either a safety pin to check for touch sensation. One of the easier things is actually to use a paper clip, because you can open up a paper clip and you can have the round edge be your blunt side and the sharp pointy part be your pointy side. And then even later when we talk in the neurological exam, we talk about 2-point discrimination. You can open up the paper clip completely, and now we have 2 separate points. So kind of like one paper clip is doing 3 things, okay? So we want to make sure we assess sharp and dull, and we want to alternate sharp and dull with the patient's eyes closed. So is this sharp or dull? And you're going to demonstrate to them first. This is going to be sharp. This is what I consider dull. Have you close their eyes, and then different parts of their body assess both sharp and dull input, sensory input. Okay, and again, mix it up, because You don't want them to become desensitized to it if your sensory exam takes too long. So again, if you have access to a Q-tip, you can basically break it in half and have a sharp and a dull, because you can have the pointy part be your sharp and the cotton part be your dull. But the easiest thing that everybody almost always has access to is a paper clip. So open it up and you've got your sharp and dull right there. When we talk about temperature sense, typically we don't need to do temperature sense, because typically your sensory exam is enough with just sharp and dull. It's very rare that you have to have somebody really try to discriminate temperature sense. Almost the only time I can remember ever doing this is when I had somebody who had an isolated stroke in the thalamus, because then they really don't have temperature input, okay, and they really don't understand that they need to pull away from things that are hot. So you almost do that part of an exam just to remind them that they can't leave an oven on and then go touch it, type of thing. Okay, they can't trust things because they can't trust the sensory input into their brain anymore. So you do it for clinical exam, but it's almost just to show it to the patient as well. So you can take like a test tube, or if you had something, even if you're in the hospital setting and you had a urine specimen cup, okay, so that would be the easiest way. You fill one with cold water, fill one with hot water, not boiling hot, but hot, just from the tap, and ask them if they can assess the difference between the hot and cold temperature, okay? You could heat up a tuning fork with cold or hot water, but it's almost better to just essentially either put it in some type of a flask, but typically what we always have access to is a urine specimen cup, okay? So light touch, again, wisp of cotton. We're going to touch very, very lightly to the patient. It should be very gentle to their skin. You said to ask them to respond when they feel it, okay? And compare one area to another. So again, the other day when we were talking about cranial nerve 5, the trigeminal nerve, and we're looking at different distributions on the face, basically you're touching forehead, you're touching the upper part of the cheek, and then you're touching the lower part of the jaw. For somebody who might have had a history of say, trigeminal neuralgia, and let's say, for example, they had surgical intervention to kill the nerve, which is one of the treatments for it, okay? So you would assess one side of the forehead to the other, one cheek to the other cheek, to see if they've actually lost sensory input there, because they should have if they had effective surgery, okay? So you want to compare side to side and make sure they're symmetrical. We talk about posterior columns, so position and vibration sense. One easy way to always think of position and vibration sense, as we'll continue to talk, is diabetes. Because these people lose that peripheral innervation sometimes kind of early in their diagnosis if their blood sugars have been all over the place, okay? But again, fine touch, again, we're going to synapse in the medulla, cross, and continue on up to the thalamus. So when we talk about vibratory sense, and almost always we start on the toes and we move proximal, again, until we can, if we have someone who doesn't have it in the great toe, until we can find out where they actually regain vibratory sense. So you're basically taking a tuning fork, hitting it on the side of your desk or the chair, and you're putting it on their toe, and they should be able to feel that. Okay, if they can't, you start to move proximal. And again, one of the best diagnoses to think about is diabetes, because they start to have loss of those distal, very, very fine nerves that are finer than your hair, primarily because they start to have micro infarcts to the arteries that supply the nerves, and therefore the nerves die. So they lose that vibratory input, okay? Same thing with proprioception, okay? So you should be able to move the toe, and you don't just always want to go up or always want to go down. But we typically use the great toe. If you're going to use the fingers, just make sure they spread their fingers, because you don't want it like gliding right next to the other adjacent phalange and kind of throwing things off. I'm sure, has anybody seen like some people's feet and some toes are going this way and some toes are going that way? Don't break their toe to separate their toe, like use a different appendage, okay? But you want to go up or down, and you want to make sure that they should be able to know based on proprioception whether the joint is up or down, okay? And again, when we talk about proprioception goes directly to gait and balance. Remember, proprioception within all our joints, not just our big ones. Proprioception, vision, cerebellum, they all go to balance, okay, and coordination. How am I doing? Okay. So we talk about discriminative sensations. We're going to finish early today, okay? We talk about discriminative stuff. We talk about stereognosis, graphesthesia. We'll talk about these 2-point discrimination, tactile point localization, which is essentially the same thing as extinction. The ability for the sensory cortex to basically input all this information and correlate it to the proper body part. And that's what you're looking for. So again, it's dependent upon touch and position sense. So those got to be intact for you to basically progress onto this type of examination. And really in terms of when we talk about graphesthesia, we're looking for very subtle changes in their neurological exam. So if you have somebody who comes in with a stroke, you're not getting all the way to 2-point discrimination. Probably not, okay, because you already have your diagnosis 10 minutes ago. This is somebody who comes in who has maybe very subtle findings. Let's put it this way. 33-year-old female presents, she's Caucasian. She had one episode of transient monocular blindness that lasted about a day, scared the bejesus out of her, but she couldn't get her appointment for 2 weeks to come and see you. Then she gets referred to a neurologist because by the time she sees you, she's normal. And the neurologist is worried about what? 33 MS, right? 33-year-old Caucasian female, 20 to 40-year-old white female with, especially with transient monocular blindness, MS until proven otherwise, okay? So, but basically, they're coming in, so then you're starting to get to graphesthesia, stereognosis, okay? You're getting all the little fine points in terms of your neurological exam, okay? You're not doing this on every patient. So basically, you always want to kind of carry some change with you, right? So you don't want to put a nickel in someone's hand. Why don't you want to put a nickel in someone's hand? Smooth edges, okay? So a nickel, penny, smooth edges. Not because they're cheap, okay? But a dime or a quarter has ridges around the sides, right? It kind of has a better raised face on it. Most people can distinguish between a dime and a quarter just because the size difference is so big. Nickel to penny, they might know it's a coin, but you kind of want them to be able to tell a little bit more about it. So if you put a quarter or a dime in someone's hand, and truly, I know it sounds strange, but as long as they're from the United States, okay, don't do this to somebody who's vacationing here and their money and currency is different somewhere else. I gave my brother pounds to go to Scotland, and he was like, "What is this?" I'm like, "I don't know. Here's some money." So you want to make sure that you're using stuff that's appropriate for the patient's nationality, okay, especially if they're out, because we have a huge German population here, just in case you guys didn't get the news flash. We have lots of people who travel here from Germany. You put a quarter in their hand to do this exam, they may not know what it is, okay? But again, they should be able to very easily detect it. Something other people use is they'll put a pen in someone's hand. And with eyes closed and kind of feeling it, they should be able to tell that it's a pen. When we talk about graphesthesia, so again, graphesthesia with an open hand, and again, they have to have intact sensory function, like essentially sharp and dull better be intact, because if you're going to draw on the palm of someone's hand and they can't feel you with sharp and dull, they aren't going to be able to tell you what you're drawing on their hand to begin with, right? We always used to play that game, well, girls did. I don't know if boys did. Boys probably didn't when you were growing up. You know, you'd trace something on somebody's back and you'd ask them what they were doing. This is what we did, guys, for entertainment during the summer. But, you know, now you draw it on someone's hand. Same type of concept, graphesthesia. So you should be able to either draw a letter or more, even better would be to draw a number on someone's palm. You don't have to actually draw it with a pen, but you would trace it with your finger, and they should be able to appropriately tell you what number they're tracing, right? Because that sensory input should be intact coming up to the thalamus and coming up to the sensory cortex. All right, let's take a break, and then we'll finish early.